Good morning. Good morning, everybody.
Good morning.
We are going to discuss the leprosy, and we have two experts. One is National Dr. Vikrant. He is a senior consultant dermatologist and vast experience in clinical dermatology. And Dr. Claudio, he is the president of Brazilian Association of Leprosy. So I have a few questions about leprosy.
Okay.
So we will have discuss it. What do you think, whether the leprosy is eliminated? Is it really eliminated?
Well, if you look at the data, you see that we have problems in accepting elimination of leprosy as it is. Less than one case per 10,000 inhabitants. What we believe is that we lose expertise a long time just because leprosy was declared elimination in 2000. So it was declared eliminated in 2000. So people forget that leprosy still exists. Even students that are at the university, the professors, everybody, people that are on the field. So leprosy doesn't exist anymore. When you say leprosy is eliminated, people think that doesn't exist anymore. And they stop to search for it. So we have many cases undiagnosed, especially on fields. Then this is necessary to check.
I think the basic problem with this is because it is eliminated, the control program is scrapped.
Yes.
And that is how we are suffering because the expertise is losing. It is managed by a general medical officer along with other programs. So the expertise in the field of leprosy is probably going down, and there may be a problem. So we still need a lot of work to be done at least to eliminate leprosy.
So how you diagnose the cases? Means for early diagnosis, what you do, or what you do in doubtful cases?
Well, I don't know exactly why, but we decided, or somebody decided, or maybe the World Coordination of Leprosy decided that leprosy was a simple and easy disease, and that clinics only clinics was good for deciding if you have a case or not, and there is no laboratory examination for leprosy. Even S-diffes bacilli, at the slit skin smear, was gone. So there's nothing, there's just clinics. And in 21st century, to think about disease only decided only by clinics is something it's strange. We have many tools for other diseases, for HIV, for hepatitis, even for TB. We use PCR today. Why we are not using PCR to leprosy? There are many papers showing that PCR can improve the diagnosis. So if you use slit skin smear and S-diffes bacilli, then you have a positivity in 15% of the patients, of all patients, 15%. But if you use PCR, you can go up to 80%. It's a huge difference. And
What are the samples used?
One you see the bacilli, and the other you check for the DNA, but the result is the same. The DNA is there.
What are the samples you use for PCR?
We use the same samples, it's just a slit skin smear, because we are doing research of that to compare both. So we use slit skin smear to compare S-diffes bacilli and DNA by PCR, and the difference is huge, especially in early cases, because there are many early cases that people sometimes say that we may possibly be misdiagnosing a case. But if you do qPCR in somebody that you clinically examined, and you find clinical, even very faint clinical evidence that that person may have leprosy, and you do PCR and the PCR is positive, then you confirm the case. And you treat very early. You avoid disability and break the chain transmission. It's very clear.
I think for TB, the PCR setup is there in every district hospital. It is done free of cost for TB. So same machinery is there. What you need is you just need one primer for leprosy.
Yeah. Means
So if some leprosy research institute can create that, it will be very easy though. Every machinery is there, just you put one primer and you can diagnose rifampicin resistance, you can diagnose leprosy. So it's
Yeah,
done
it
for
will be
TB,
easy,
why not
very
for leprosy?
Yeah, this is another thing that is important and interesting that was talked now.
already it is for TB, so why not for leprosy?
Yeah, why not for leprosy? And more, you can check for resistance.
Yeah.
We are seeing the first years of resistance in leprosy. If we don't do nothing, we will have the same problem that TB has today in 10 or 20 years. Many people with leprosy, where mycobacterial lepra is resistant to one or more MDT drugs.
And what you say about treatment, I would rather say it's better to over-treat than under-treat.
Yes.
So in little
Yes.
doubtful cases, if you don't have resources, counsel the patient and better treat it. That's what my policy. Better to over-treat.
Sir, many a times orthopedician and neurologist send a patient with hypoesthesia and anesthesia. So we suspect it clinically as a pure neurotic absence. So how you approach these cases?
I think as a dermatologist, we don't investigate that much, at least a leprosy case. But I have seen with my neurologist friend, whenever I send them a case of neurotic leprosy for opinion, he advises no biopsy.
No biopsy.
And many times it is very conclusive. It tells you, even though you are clinically doubtful, the biopsy report tells us this is a leprosy, and that helps to diagnose many of the neurotic leprosy early. But that is done only for pure sensory now. But it can be easily done, not a very big thing. So can be easily done in all doubtful cases.
Nerve biopsy.
Nerve
Your
biopsy,
take is on
yes.
nerve biopsy. That
Yes,
every case
yes.
should be biopsy.
Yeah, in doubtful cases of now
What do
involvement.
you think?
Well, I believe we simplify it a lot. This is not simple. So my question is, why we don't use the tools that we have today? We have electroneuromiography. We have ultrasound.
Yes.
Yes.
So it's possible to see the thickness of the nerve using ultrasound. And ultrasound is not that difficult to have. So it's possible to use ultrasound
Yes.
to check for the thickness,
Thickness,
of the
thickness
nerve.
of the nerve.
We need to start to use that on leprosy because leprosy came to the 21st century and we stayed on the 20th century.
Yes.
So we need to come together with the tools that we have today.
Even-
Ultrasound, electroneuromiography, qPCR, we have to use that on leprosy.
Yeah, even FNSA tells about the type of nerve involved.
Yeah.
Yes, I think we need to investigate leprosy cases, which we usually don't do it. The
Yes.
facilities are available. Why not do it for leprosy patient?
Yes, and the thing is that very clear cases that we call classic cases, they have shrinked, but we have more cases like that, primary neurotic and with very faint lesions and these things, and we have to find them. Otherwise, we are not going to check for all people, and it's not going down.
Vikrant sir, how do you treat the cases of lepromatous poles that the cases have a very high bacillary load? So do you treat it with only MDT? Do you modify MDT? And if yes, what are the modifications you do?
With high bacillary load, I think most of the private practitioners, if you discuss, they feel only MDT may not be adequate. So they need to modify. That's my personal opinion also. I use rifampicin more frequently. Like in US, they use rifampicin daily.
Yes, yes.
So
How
why
many-
not? Because it's not that costly drug. I mean, I think the basic aim of introducing this MDT is for the economics, that you use
Yes.
rifampicin less frequently because it was costly.
Yes.
It's no longer that costly. Patient can afford. So I do, my personal opinion, you can say, we should use rifampicin more frequently. So that will
How
lead
frequent?
to
How frequent?
most time for multibacillary patient, I use rifampicin and ofloxacin daily.
Daily.
For at least for 30 days, which may be more depending on the clinical response.
What
But
is your opinion, sir?
I use it definitely.
Yes, I agree with that. It's in Brazil you're using definitions that come from TB. So after 12 months, if you if you still have clinical disease that you believe the patient's not cured, so we call insufficient therapy, and we do 12 doses more. After 24 doses, if you still believe that the patient is not cured, you can talk about therapeutic failure. And after therapeutic failure, you need either to change the drug or to check for resistance in the bacteria. So we are doing this more. But I believe the situation that was told here, using rifampicin more frequently, daily, as they do in the US. In the US, they treat patients with rifampicin daily for 2 years. This is the standard therapeutics. And we use once a month. So it's a huge difference.
That means you added 2 bactericidal
Yes.
drugs,
Yeah,
rifampicin and Oflox. You
Yeah,
use
that is what,
simultaneously in the
yes,
cases
yes,
who
and-
have a very high bacillary
Yes.
load or towards cases of a lepromatous.
Yes. But and I also add steroid many times along with this to prevent, because of the bacterial killing and likely risk of exacerbating the lepra reaction. So I do combine this with steroid most of the cases.
Yes, even I am using it for longer duration. So I start with 2 bactericidal drugs and simultaneously steroids. It definitely reduces the frequency of reactions.
Definitely, and rifampicin and ofloxacin are not very costly drug. Of all the second line of drug, maybe minocycline and clarithromycin are little costly, but oflox and rifampicin are at a very reasonable rate. So most of the patients, I think, won't find it that costly. So I think, in fact, I feel that initially for a high endemic area, in the control program, Indian control program, there was a one intensive phase where rifampicin was used more frequently, sometimes 3 weeks or 2 weeks. I think that need to be reintroduced, especially in the area where leprosy is still incidence is very high.
You know that there are some researchers defending, Dr. Joel Almeida, for example, defending that we treat BL and LL patients for longer times than 2 years. Because he believes that that patient may keep the infections going on in the community if we stop with 12 doses or 24 doses. So he's defending that we keep giving drugs for the patients. I believe we may find a way to put together this with maybe daily rifampicin or another drug like ofloxacin or minocycline that we use in Brazil. So we have to put this together and try to figure out what's the best for the patient.
I think the modification should have one thing, that minimum is WHO MDT, that you have to give.
Yes.
Whatever drug you use, you cannot say I'm using 4 drugs, I'll give only 2 months. No, you have to use WHO MDT.
Yes.
In addition, you can have, depending on your expertise and the availability of the drugs, you can go on adding other second line drug, or maybe rifampicin more frequently, or maybe you can add ofloxacin and minocycline.
That means you modify the MDT, and that depends on the bacillary load or the pool of the disease.
Yes.
Or if it is of the lepromatous pool, you do the modification. So when you how you suspect resistant cases clinically?
See, this is basically when you treat, and after 3 months or 6 months, at least you should see good improvement.
Yeah.
That is what we normally expect.
Yeah.
But sometimes you give the patient the treatment 3 months or 4 months, and patient doesn't observe any improvement, and then the patient also is find it's very difficult to maintain the same treatment for a long time without improvement.
Do you think that the person who has completed his course, means he is released from treatment, and still he is getting the ENLs, recurrent ENLs, could this be resistant?
At 1 year, that is after completion of the standard, if you clinically we decide, because smear will remain positive.
Yes.
So the study says maybe after a long time it will go. But if I see the smear and if I feel there are some live organisms, my personal opinion, I do continue MDT for some more time.
Yes.
Maybe 6 months or more. Maybe I add rifampicin or ofloxacin. in that situation.
What is
Yeah,
your
I
opinion?
believe we have to be very careful with the use of prednisone and thalidomide for a long time. So if the patient is dependent of prednisone or of thalidomide, we need to recheck either if he's really cured or not. So we need to check for the mycobacterial lepra if there is resistance or not. So we need to check more because we have many people now using prednisone for long periods because of reactions or neuritis, and we do not recheck them. We just keep giving them prednisone or giving them thalidomide, and we need to check if there is any other possibility for them.
How you treat the resistant cases?
Well, the resistant cases, we have in the Brazilian government make available ofloxacin and minocycline. So the patient, it's possible for the patient to access, and it's possible for the doctor to ask those two drugs from the government. So yes, it's possible to change one of the drugs, rifampicin or dapsone, because we don't know nothing about resistance to clofazimine. So, but rifampicin or dapsone, if you check for resistance and there is something, then you can change and use ofloxacin or minocycline or even clarithromycin. And we are using also, not only me, but other groups in Brazil, we are using moxifloxacin. There's a very good drug
More
for TB,
potent than...
and it's a bactericidal drug,
Yes.
so we are starting to do that, and the results are good, but I think we believe a try on that.
I think
how
that
you
there is no definite guidelines,
Yeah.
WHO guidelines,
Guidelines
Yes.
are
what
not
to
there.
do for
Exactly,
resistant
for
cases,
resistant cases,
and
that-
it depends on the individual experiences. But what is logically, there are other drugs, second line drugs,
Yes.
like Oflox, minocycline, clarithromycin. So this we have to use, and I think for leprosy, no treatment is short term. I mean, it takes at least few months. So maybe for 6 months at least further.
Yeah,
we
even
need to
even the
this-
expert group has mentioned it, use it for 24 months, and the first 6 months is an intensive
Yes.
phase in which the rifampicin is given daily,
Yes.
and the other drugs are continued for next 18 months.
Yes, I think it requires definitely longer treatment.
Definitely longer treatment
More
for the-
drugs, MDT, including more drugs for little longer duration. But I think that is basically clinical judgment we take. You see clinically whether the patient is improving or whether the still inflammatory, still some induration is there.
Tell me something about childhood leprosies.
Childhoods. Well, we go to the houses of the patients. I live in Amazon, and I go to the houses of the patients and examine all the families. And the families sometimes have 10 members, 15 members, 20 members living sometimes in the same house. So we have to check for everybody. And we are doing slit skin smear for PCR, even in contacts.
Contacts, healthy
Yes.
contacts, healthy
Yes, health contacts. I examine them, and if I find something, we define the case there and start treatment. But we collect slit skin smear and go to the laboratory and check for PCR. So in 80% of the cases, we have a positivity in PCR. So PCR is good. It's good
PCR
for
is good.
early diagnosis. And even those contacts that I examined can't find nothing, 20% are positive for PCR. So we have to follow those 20% because I believe
They are the
they
source.
they are the sources,
They are the
and they
source.
may be clinically evident in the
something,
future.
yeah.
Yes.
That means the PCR is definitely helpful.
Yeah. This time that we live now, I think PCR is definitely a good tool.
So, Vikrant sir, how frequently you see the childhood cases?
Childhood we do see, but not that frequently.
Not
we do
frequent.
see, not
That-
very frequent. So maybe because it's a long incubating phase, so maybe it's evident after a few years.
Yeah, might be.
So it's completely different because I work also at the reference. So if I stay on the reference, I see advanced cases even in children with grade 2 disability and these things. So these cases are the cases that come to the reference. But when you go to the house of the patient, you see many early cases. It's completely different. And it's difficult. It's not easy. It's not an easy task that somebody in the field with little training can do. No, it's something that it's more difficult to diagnose.
For which I think the field work folks should be there.
Yeah.
Yeah,
The
field
quality
work should be
control-
there by the experts.
Yeah.
Yes.
By the experts.
By the
Yes.
expert.
Yeah.
Yes.
Yes.
So how you treat the cases of steroid dependent ENLs? Recurrent ENLs?
Thalidomide nowadays is a good option.
Yeah,
So I do use thalidomide. Unfortunately, is little costly.
costly.
So it's available at many of the government centers, may be free, but for practitioner also, we do get sometimes at the subsidized rate, but still costly. But I think it's worth it because it otherwise severe type 2 leprosy patient doesn't go to work, is all the time bedridden,
Recurrent
sleeping. So
steroid.
at least with this drug, patient can manage to go for his
How you give thalidomide?
I usually start at least first few weeks steroid and I introduce thalidomide. Thalidomide, because of the cost, I tend to use it little, I mean
Lower
not very high
doses,
dose, so
lower
maybe
doses.
100 BD.
Or 100 TDS.
Then many times along with steroid 100 BD in many of the patient is adequate, and then over a period of time gradually taper off.
You stop the steroids and continue
yes,
the
yeah,
thalidomide,
yes,
or you stop both the things.
No, steroid I stop, and thalidomide also, because there's a one important thing is the cost constraint. So
Cost
we have to use for a minimum possible duration. But I think with thalidomide, most of the type 2 lepra reactions are well under control.
What is your opinion?
Yeah, for thalidomide, usually for most of the patients, I start with 200 milligrams per day.
200 milligrams.
200 milligrams per day, and I usually do 30 days. And after 30 days, I diminish to 100. And usually in 2 months, you can control the patients. Most of the patients can be controlled in 2 months. And then we try to remove. If this guy starts to have again and again, you have to check for other things like the resistance, as I told you before.
Yes,
So,
yes.
yes.
Clinically suspected resistant
Clinically
cases are
suspect
generally
resistant
steroid
cases
dependent,
with
recurrent.
steroid
ENL.
dependent and thalidomide dependent. Those guys need to be tested, and we don't know all the places of resistance on mycobacterium lepra. There are recent papers showing that probably other parts of the genome of the mycobacterium lepra is responsible also for those cases for resistance, but we don't know yet. So we need to clinically define that because it's necessary for the patient. This is very important for the clinician.
What is the role of immunosuppressives in recurrent ENLs? In steroid dependent, thalidomide dependent, recurrent
we
ENLs?
have-
What is the?
Well, we have some experience with chronic neuritis using cyclosporine.
Yes.
Yeah, we did cyclosporine for chronic neuritis in some patients, but some of those patients, after a while, I had to treat them again. So showing again that the bacilli was there yet. And at that time, if I had the experience that I have now, maybe I would treat them before that. So yes.
What
I
is
think
your experience?
I think
Vikrant, sir?
there are reports that azathioprine was effective in some cases and methotrexate was found to be effective. But what I have found, no single immunosuppressant is consistently effective in all the cases.
Yes.
Yeah,
So
depending. Yeah, that's true.
I feel steroid and thalidomide are usually my preferred drugs nowadays.
And some are very expensive. Cyclosporine is very expensive.
Yeah.
Yes, expensive is the
Yes.
issue. In my institute, I have used IV cyclophosphamide. I give a single pulse in these cases. So I tried it in around 20 patients, and I found that the effectivity is around 60%. That means 60% patients who are on the steroid dependent recurrent ENLs after cyclophosphamide, they are not getting the ENLs.
Okay.
But that is good. But only thing I feel while using methotrexate, we have to be very careful because we are already using dapsone,
Yes.
Yes.
which
Yes.
which may have a problem with methotrexate.
Yes.
So I think if at all I did try methotrexate in few patients, but then I discontinued dapsone.
Yes, still reports of biologicals are also there.
maybe I think
Not,
beyond
I
the reach
don't
of
have
a
any- I don't-
leprosy patient, definitely.
Yes. Nice talking, Claudio sir. Nice talking, Vikrant
Yes.
sir. Thank you both of you.
Thank you very much.
Thank you very much.